Greetings, everyone. This is Prosthodontics on Friday, which explains implant prosthodontic steps and its side effects in a very easy and interesting way. As we kick off October, today we're going to talk about implant prosthodontic occlusal adjustment and correct way to do finishing. And this lecture is going to be given by Professor Lee Jun-seok of Dankook University Prosthodontic Department. Greetings. Thank you for appearing on Prosthodontics on Friday once again, and I look forward to your lecture. Before you begin, could you briefly explain about today's lecture? I'm going to talk about occlusal adjustment of prosthesis and finishing. I'm going to talk about what acceptable occlusion is,
the difference with implant occlusion.
I'm also going to talk about the clinical tip for occlusal adjustment and finishing as well as polishing. And then I'm going to summarize. The final stage of implant prosthesis connection, occlusal adjustment and finishing polishing. I'm sure this is going to be a very interesting lecture. If you're viewing from dental site, on the right side of the site, you can use the chat screen to communicate real time. Feel free to raise your questions, and these will be raised during the Q&A session. Starbucks coffee coupons have been prepared for those who participate in the chat as well. Raise your questions on the chat screen and win your coffee coupons. I look forward to your keen interest, and let's begin Professor Lee Jun-seok's lecture. Greetings, I'm Professor Lee Jun-seok of Prosthodontic Division at Dankook University, and today I'm going to talk about occlusal adjustment of implant prosthesis and correct way to do finishing. I'm going to talk about the following contents. Occlusion. This is a part that a lot of dentists and dental students find difficult. I'm going to talk about what acceptable occlusion is, and what kind of occlusion is recommended for implant occlusion treatment. I'm going to talk about clinical tips for occlusal adjustment, finishing, and polishing. After that, I'm going to summarize and conclude my lecture. I'm going to talk about acceptable occlusion. Physiologically good occlusion needs to satisfy the following 5 criteria. The most important is at the centric relation, there needs to be stable posterior holding stop, or else occlusion is not good and extensive restorative treatment may be necessary. Anterior guidance should be in harmony with the envelope of function, or else unfavorable force can be applied to posterior or excessive force can be applied anteriorly. Immediate disclusion should occur in protrusive movement. For lateral movement, there needs to be no interference in non-working side, and on working side, the posterior should immediately open due to canine or harmonious contact should be made. I will use upper and lower first molar to explain the path that is achieved during anterior excursive movement. In centric occlusion, the distal buccal cusp is in contact with centric relation of upper molar. This is in red. In centric occlusion, the mesiolingual cusp of upper molar is in contact with central fossa of lower molar. In the image, it is in blue. From here, if it moves to the working side, a path is formed as shown in yellow. If movement is towards non-working side, as shown, the brown path is
Here.
When a protrusive movement is made, the path is in green. Mandible is moving, so the path is made anterior when protrusive is made on the maxilla. On the other hand, in mandible, it is towards posterior. If you want to make a canine guidance, all path needs to be removed except for eccentric occlusion. If you want to make a groove function, remove the protrusive path and non-working and just adjust working side. Let's look at chewing cycle and pattern. Chewing cycle vary depending on individual, but it takes approximately 1 second. As shown in the diagram, when the mouth opens, it starts off slow, and when it closes, it starts off quick and ends slow, resulting in occlusion. Another point you need to note is the red. The speed is very slow here. This is where guide occurs as teeth are in contact. Chewing pattern is different for different individuals, but on the anterior, when looked from the sagittal view, this is as shown in the left, and the posterior, if you look from the frontal side, it is shown like what is displayed on the right. For regular pattern, as the jaw opens and closes, there is a consistent pattern. These grouped together in an elliptical form is called envelope of function. An occlusal relationship which is in harmony with the shape needs to be achieved. Another point we need to remember is that unlike what we learned in the class, actual occlusion does not occur through excursive and protrusive movement at centric occlusion. When jaw is open from lateral as it closes, the centric occlusion is achieved. And from anterior, the jaw closes and centric occlusion is achieved, and the path is made on the other way around. Please take note of this. All patients have different form of envelope of function, but we need to make restorations so that harmony is achieved with the patient's envelope of function. Or else, if we make prosthesis like what is shown on the right, there can be multiple problems, such as wear on the antagonist, reduce the lifespan of the prosthesis, or TFO. I've briefly talked about occlusion, and these rules need to be applied the same on implants. Now I'm going to talk about implant occlusion. Implant does not have PDL, and for single tooth implant, anterior lateral guidance should be gained from natural tooth, and contact should only be made when the patient bites strongly. That is the implant protective occlusion. If we restore fixed prosthesis in the posterior area, anterior guidance should be gained from natural tooth. If canine is not healthy, group function occlusion can be formed. In the posterior, solid vertical stop needs to be provided. Therefore, implant protective occlusion, which is applied to single restoration, cannot be applied here. Therefore, central occlusion needs to be made stable, and you need to design so that excursive force is reduced. In the case of full mouth restoration, depending on what the antagonist is, it differs. In the case of removable full denture, bilateral balanced occlusion can be used. If the antagonist is natural dentition, group function or canine guidance with shallow anterior guidance can be used as much as possible so that excursive force can be minimized. And in posterior, in centric occlusion, 1 to 1.5 millimeter of horizontal freedom should be given. However, even now, there is no clear guideline on occlusal adjustment of implants. And there is a very little evidence-based research on implant protective occlusion. However, the tactile sense that is felt in mastication Depending on tooth and antagonistic condition, the tactile sense between teeth is 20 micron and between implant is 64 micron. It can differ from 20 micron to 108 microns, and we cannot ignore biomechanical mechanisms as well. We need to consider the previously mentioned factors, and to achieve protective occlusion, the following are very important. If you look at the image on the right, between the red line, there's a space, and this space between the two lines is where the guide can be achieved. Therefore, if you make a group function compared to adjacent teeth by making a shorter
Guide is made on the teeth first and then on the implant.
and the timed occlusal contact can be very favorable for the implant. To reduce the excursive force, changing of the shape is necessary. The upper and lower teeth are guided into centric contact. In the case of implant, as shown on the right, you can change the fossa more flat or shorten or remove guide to reduce the excursive force. Can I ask you a question? Sure. In terms of occlusion of upper and lower, and as patients age, depending on whether food is hard or soft and whether the patient has grinding habits, the occlusal
Surface,
it can have facet or it can become flat. Let's assume that it is so in the upper and lower. We need to provide restoration. And depending on a lab, at times, the prosthesis has a flat occlusal surface like that of the upper, and other labs provide a prosthesis with anatomical form. It is curvy like ball bearing. What should we prefer more? In general, as attrition occurs, occlusal contact has facets. We can think of two things. If we look at upper and lower teeth, the buccal cusp of lower tooth is guided and buccal cusp is worn down into facet shape. On the other hand, if the cusp tip of upper and lower tooth is being flattened due to attrition, even if there's attrition, if there's no major problem, there's no need for restoration. In general, when we provide prosthodontic restoration, the occlusal surface needs to be harmonious with antagonist and adjacent teeth. In the case of an implant, or if it is periodontally compromised, excursive force needs to be reduced. Therefore, in the lower, if the facet can be guided, you can reduce it and make it reflecting its form. If excursive force can be reduced, it could be of help. If the cusp tip itself is flat and is not guided during lateral movement, you can just leave it as flat. Thank you. Thank you for the good response. Please carry on. I'm going to talk about the practical aspect of implant occlusal adjustment. First, I'm going to talk about ways to check occlusion. Visually, you can check the amount of disclusion and occlusal contact and firmitas or mobility that is transferred to tooth, or restoration during mastication can be stimulated to check the strength. Especially in the case of ceramic, you can use occlusal sound to check the occlusal condition. We use articulating paper a lot, and with just that, we can only check simple positions. We need to use everything to get information You need to use all methods to understand not just the position, but the size and strength. Now I'm going to move on and talk about a basic guideline as to how to do occlusal adjustment well clinically. First of all, before occlusal adjustment, you need to check occlusal condition of adjacent teeth. At times, adjacent teeth are not in occlusion, so excessive occlusion can occur, and because adjacent teeth are weak, it can have mobility during mastication, and deep bite can occur. Second thing to remember is that the surface with a path needs to be always concave. Sometimes for ideal occlusion, the lab technicians make the occlusal surface
Convex.
reflecting the ridge. However, all envelope of function are in elliptical forms. Contact point which is guided needs to be concave regardless of whether it is anterior or posterior.
It needs to be concave.
And as shown in the middle, if it is convex, there can be many problems. Third, you need to remember that centric occlusion formed in inclined surface is not good. In the image, if you look at the dotted line over here and here, the dotted line is not really visible. Even if there is centric occlusion in the inclined surface, exertive force can be applied, and if you need to reflect this, you need to make it so that it is not in the surface shape, but only the distinctive traits are reflected. I'm going to talk about the fourth guideline. In general, as shown in B, we get centric occlusion first, and then as shown in C, we adjust the lateral occlusion.
Even if the occlusion is high, if you find the right lateral occlusion, the result becomes the same, but you can get better restoration much faster. Don't just think of centric occlusion just because the occlusion is high. Consider and measure the area of excursion and centric occlusion together and adjust occlusion as shown. You should not only adjust and polish the black dot, but you do it together with the red part. The best way to get final restoration shape.
Fifth, check articulating paper rather than occlusal contact points. As shown in this image, there is area where it is guided and centric occlusion is marked here. If you look at the centric occlusion area, you can see that there's strong occlusion. However, in terms of whether there is actual occlusion or not, instead of resorting to occlusal contact points, we need to refer to articulating paper and see whether there's penetration or if the occlusion is just not quite there yet. We can get more details such as height of occlusion and so forth. And you can see that although there is occlusal contact point on articulating paper, only other points there is a strong occlusion. And let's look at the sixth guideline. When we adjust occlusion, we need to check the strength level using our fingers. When we make a guide, we need to check the amount of shock that is applied to understand the level of inclination that is required. For instance, in the anterior area, when we guide and chew, if the prosthesis moves and if the dentist just bonds it, prosthesis is maintained just because of the adhesive. This means that too steep anterior guidance has been provided. If a certain level of inclination is provided so that the prosthesis does not move, without cementation, with our hands on, we can be rest assured that the prosthesis will last long without dislodgement. Next, I'm going to talk about finishing and polishing. Finishing refers to refinement of form prior to polishing. Polishing means using tools in different stages to provide gloss. On the left is the prosthesis with finishing, and on the right is complete with polishing. So let's look at how tools are grasped before we look into finishing and polishing. There are two types of grasp, pen grasp and palm grasp, and we need to understand both of them very well. This is because they have different traits. In the case of pen grasp, as shown in the left image, if you look at the arrow, it moves left and right as if it's rotating. This is the technique that we use when we polish very distinctively defined surfaces, and this is the kind of technique that is very used to dentists. On the other hand, the characteristics of palm grasp, this is very used to the technician. We can check from the top. A pen grasp, we need to check from the sideways, but palm grasp, you can check from the above. Movements can be made in straight lines. In fixed condition, you can move the prosthesis and do polishing, and it is a huge plus, and it can also be used for intricate areas such as connector and proximal. Pan grasp can be used for all of these purposes, and for palm grasp, it can be used for disc or wheel type. Stone and silicone for finishing or polishing gold and metal are displayed here. These are different silicone wheel options with different stone, coarseness, and grit. These are the tools for polishing ceramic. And there are kits that can be used intraorally in OSSTEM, so we can use them very conveniently. This is the polishing process of metal surface, and the most important thing is that stone is used to finish the surface. You need to do this very well. In the second image displayed, finishing is complete. The irregularities in the first image needs to be smoothened out to make a smooth surface. The wheel is bigger in diameter, therefore effective polishing is possible. The silicone point is very useful for polishing detailed areas. Thin wheels can be used in areas where there's grooves. Once finishing is complete, on each step you can use wheel and silicone point to complete it. And the final image, as you can see, you can get a very smooth, polished surface. The same process can be utilized for zirconia or ceramic. It can be done in a consistent way. In order to complete a crown, as shown on the right, in the finishing process, you need to make a smooth surface. This is very important. Once a smooth surface is achieved, the first step in polishing is the most important. The burr that I am using is green, red, and yellow. It is in 3 steps. Finishing step is most important. After using green wheel point, you use red wheel point, and after that, in high polishing stage, even if you just put yellow slightly, you can see that gloss is achieved drastically. The top image on the right is with high polishing, and you can see that occlusal contacts are made here to check. The polishing process is not difficult, but you need to start off correct to get good results. If you look at the image, from the first step, from here, this is the first step and it progresses gradually. The first image, we can see that finishing is complete. And second, third, and the final one, you can see that high polishing is done. Before the final stage, there's not much gloss, but you can get real gloss in the final stage. That's why you need to focus on finishing and then proceed with polishing. I want to emphasize on this. I want to ask you a question. For instance, zirconia, when we do finishing and polishing, when we do it really hard, you grab onto it very hard and heat is generated. In those cases, does it have negative effect on zirconia? One of the most important things to note in using zirconia is that it might go through phase transformation if load is applied repeatedly or if heat is applied. There are concerns that zirconia might weaken. The recommended way to do occlusal adjustment is to do irrigation and to use diamond burr to make adjustments. That's how we do it these days. There are many researches on possible weakening or changes due to heat generation in polishing and finishing stage. It is known that phase transformation does not occur through polishing phase based on XRD result before and after finishing, so you don't need to worry too much. Another point, when the surgeon does polishing, a lot of heat is generated and it is very hot. So I think it is important to do irrigation. Those will be effective. The surgeon will find it extremely hot, so the heat generated due to polishing will not affect the zirconia in a negative way. It needs to go several hundred degrees. We will not be able to achieve that. Thank you. Please carry on. Now I will move on to the summary. The guidelines of occlusal adjustment. As mentioned earlier, before occlusal adjustment, you need to check patient occlusion. The shape of the occlusal surface where path is made and always needs to be concave. Centric occlusion formed in inclined surface is not a good centric occlusion, so removal is recommended. But if inevitable, you can just leave the distinctive traits slightly. Occlusal adjustment order and method may vary depending on the surgeon, but if you adjust excursive movement, it will help clinically. Rather than just checking occlusal contact, you can consider multiple elements like articulating paper and fragmentus to get ideal occlusion that we want. Next, I'm going to talk about precautions related to finishing and polishing. As mentioned, the level of finishing determines the level of polishing. In polishing, coarse grit burr step is most important. Even if you just touch it slightly, you can get gloss. You need to polish in high speed, but depending on the hardness of material, you can apply appropriate force. Regardless of whether it's metal or zirconia, you need to check whether the surface of the restoration changes. You need to apply appropriate force that is not too strong or too weak. Metal or zirconia, it is kind of difficult to do polishing, but in the case of gold alloy, if we apply force using silicone point, occlusion become low, so force should not be applied. We need to be careful so that marginal damage is minimized, and in patient mouth, wear and roughness increases, so regular checkup as well as polishing within patient mouth may be necessary. This is the end of my lecture. Thank you for listening. Thank you for the wonderful lecture. I can see that you put in a lot of effort into it. We will now end Professor Lee's lecture and move on to Q&A session. Now let's look at the real-time questions that have been raised on dental site. ID Kehero, thank you for the wonderful lecture. ID occlusion, I think occlusal adjustment is very important in implant prosthodontics. Thank you for the wonderful lecture. ID workflow is asking a question. After occlusal adjustment of ceramic or zirconia restoration, what kind of disadvantages could there be if finishing or polishing is not done sufficiently on the rough surface? If you do not do finishing or polishing appropriately, and if rough surface remains, what occurs? In the days I went to school, I was taught that porcelain in restoration should not be made because antagonist wear occurs. However, when I became an intern, there were talks of how high polished surfaces were better than glazed surfaces. It's the same with zirconia. When you use ceramic, the most problematic thing is wear on the antagonist. When you look at the manual literature that provide theoretical basis, when you compare zirconia with enamel, veneer porcelain, polished zirconia, glazed zirconia, polished and glazed zirconia. Polished zirconia has the most smooth surface and it can reduce the wear on the antagonist. In the past, people talked about glazing, but these days, just with polishing, you can get good results. Yes. The next best option is polished and glazed zirconia. It has the second smoothest surface. In aesthetic area, you need to do glazing. However, in the case of posterior area, polishing is enough to minimize wear on antagonist. You need to use prosthesis long term. As people live longer, inevitably in the posterior area, the vertical height is reduced. Sufficient polishing is required to minimize this. If polishing is not done sufficiently, patient will feel discomfort. It will not feel nice to the tongue, and if you look at microscope, there will be food impaction. So I think polishing should be done sufficiently. IDD 101301. Does occlusal force need to be different depending on prosthesis, porcelain, zirconia? I'm not sure I understood the question, but occlusal force differs from patient and we cannot really change this. I think the question the person asked is whether if the periodontal condition is bad or if there are different materials being used. Depending on periodontal support, the treatment plan should reflect such and differ in occlusal force and reduce the excursive force. However, I don't think it will differ significantly depending on prosthesis. I think the question is whether there is any difference in occlusal force transferred to the antagonist. For instance, in the posterior area, is there difference in using gold crown or zirconia? It may feel like there's a difference, but if you look at the researches, almost all of them say that there's no major difference. No difference depending on the material. Yes, no major difference. Patient muscle or periodontal condition may affect it, but in the case of resin, there are discussions that it may reduce shock. However, if you look at the result, if you look at Dr. Bronymark's textbook, it says that resin can cushion some of the shock. I think you need to test this. If you use resin compared with zirconia, there can be less shock. It was written in Dr. Bronymark's textbook. Well, we can test what it's like today. Can you scroll down a bit? What kind of prosthesis is better when you do implant prosthesis? Easily put, should we use gold prosthesis or zirconia or PFM? I think this is the question. To give you an answer, I really cannot say which is better. I think all is good. Everything can be used, but personally, in terms of antagonist wear long term, I think gold occlusion is most physiological and convenient. So if Professor Lee is to do prosthesis, you want to get gold. Yes. Rather than zirconia, you prefer gold. In general, the cost of gold is very expensive, so a lot of people use zirconia. With the development of digital dentistry, it has continued to develop, and actually gold is difficult to mill and print. Using digital dentistry, you can easily mill and print the zirconia prosthesis. In my opinion, in overall dental field, excluding exceptions, I think rather than gold, people are going to use more zirconia. However, when we're asked the question, which is better between the two, most dentists answer gold is better. Another point I want to discuss is that you need to consider the antagonist. If you have zirconia crown on the upper, you need to make a zirconia crown for the lower. If you use zirconia in the upper and use gold crown in the lower, wear can occur very excessively. So you need to consider the antagonist. Yes. You need to consider antagonist so that it goes in harmony. ID Yeonji, she, 61-year-old male patient, number 45, 46, 47. There's edge bite, bruxism, and clenching habit. There's very severe attrition. The patient is not considering orthodontic treatment, and after extraction of number 45, 46, and 47, if we need to restore implant in the edge, considering the relation with the antagonist bite form, is it better for the patient to have groove function rather than canine guided occlusion? For number 45, 46, 47, is it better to have groove function or cuspid guided occlusion? The bite is edge to edge bite. I cannot answer accurately with just the information that has been provided. If the patient is 60-year-old and has a bruxism and clenching habit in the anterior, you can remove overjet or overbite. And at present, I don't think canine guidance is possible. It's very difficult. And if you need to provide an implant in this case, you need to minimize excursive force. You need to make the posterior occlusal surface almost flat. And excluding centric occlusion, excursion needs to be minimized. Regular checkup is necessary.
I'm sure the antagonist is the same.
You need to consider these factors, and materials need to be chosen wisely so that it is in harmony with the antagonist. Regular checkup is most important. For bruxism patients, often, no matter how great of a prosthesis you make, it can fracture within a couple of years. If the patient has sound canine, if cuspid protective occlusion is possible, I think the treatment should be headed that way because the patient has edge-to-edge bite. Even if occlusion is nice, cheek biting can occur because of edge-to-edge bite. And if you give growth function, I think cuspid canine guided occlusion is better for disclusion and for cheek biting as well. For instance, as Professor Lee has mentioned, if there's wear in canine and if cuspid protective occlusion is not possible, then we have no choice but to give growth function. In those cases, you need to be cautious. Don't provide final prosthesis, provide temporary bridge and have the patient to use it for some time. Keep your eyes open for possible negative effect before you provide final prosthesis. Next question is from ID Awesome. When I do occlusal adjustment, there is a scratching sound and at times it's difficult to find where it's coming from and it continues to come even after polishing. Please provide me with a solution. Sound during occlusal adjustment. At times it does occur. I think such a sound occurs when you use porcelain or zirconia. I think the reason is because there's interference somewhere. Yes. The fact that it continues to come even after polishing, it cannot be solved just with polishing. You need to take an overall look at the occlusal adjustment and make it smooth. Do occlusal adjustment and then do polishing. This is not because it's rough. It's because somewhere in the occlusion, something's hitting first before the others. You need to adjust the occlusal overall and then do polishing. Yes. Thank you for the wonderful lecture. Prosthodontics on Friday. It's very interesting. There's another question. ID 우리들이. If prosthesis is already placed and if it is not visible to take it out, is there any tips or precautions that I should take when I do finishing and polishing within patient mouth after occlusal adjustment? We need to do polishing outside patient's mouth and after temporary cementation, it doesn't come out. And if we need to work within the oral cavity, what are some of the tips that you can give? When you do it within patient mouth, because this is not a straight angle, there are some risks. You need to approach it in the right position and you need to do some retraction and irrigation as you do polishing. Contra angle option is also available, and in terms of effectiveness, the thick one is more effective for polishing and you can use it, and within patient mouth, contra angle is very good. OSSTEM has a cup type of option, and I've tried it, and it has very good accessibility, and it was very nice. It was one of the things that OSSTEM did right. Do irrigation sufficiently. I think the principles are the same. You need to focus on the first step of polishing sufficiently, and then if it is done nice, move on to the next step. In the following stages, even if you just rub, you can see the effects. If you do it step by step and following each level, you can get good results. Contra angle is very easy and convenient. That'll be the answer. It is ID Yeonji-shi. Even if there's edge bite tendency, when I do occlusal adjustment, which is better, slight contact at lingual cusp or disclusion? Or do you have any other tips? Even if the patient has edge bite tendency, should I make slight contact at lingual cusp? By lingual cusp, I'm guessing it is lingual cusp of lower because it was number 45, 46, and 47. Which is better between slight contact at lingual cusp or disclusion when the patient is edge-to-edge bite? I think this is the person which mentioned the patient with posterior issue. Personally, I believe there's no correct answer or perfect solution. In those cases, I make a clear vertical stop. As I mentioned earlier, rather than dividing working and non-working side and excursive movement, because the jaw opens and closes, in normal mastication, look at the antagonist and make it non-anatomical tooth. The vertical load should go to the occlusal plane and horizontal plane, and that is the best. I do not believe having slight contact in lingual cusp will have special effect. I agree. And in those cases, you need to look at adjacent tooth and antagonist on the other arch. You need to refer to it. It was number 45. It looks like it's to the right side. You need to look at lower left. Refer to how the shapes of the teeth are. You need to make the same pattern. That is my opinion. IDSS. Recently, there are theories that it is okay to give excursive occlusal force on single implant. What is your opinion? Giving excursive occlusal force on single implant. These days, in the case of single crown, some people say it's not necessary to give implant protective occlusion, and vertical occlusion is made in light bite. And it doesn't matter if excursion occurs on the implant just as the same as adjacent teeth. That is not to say that bone issues or antagonistic issues will rise for sure. Even if it is okay, if a lot of excursive force is applied, there is higher possibility of screw loosening. And therefore, in terms of reducing such possibility, I think it is more favorable to minimize excursive force. As we age, we become more cautious. I'm a bit older than you, Professor Lee, and I'm more cautious. In the past, when I lectured, I asked questions to my students, whether they wanted to live short and leave a lasting impression or live long and leave not much of an impression. I believe we need to elongate the implant life. So we need to remove unfavorable forces being applied to implant so that the patient could use the implant long. And some people ask me, What's the big deal? What's the point? Why not have the patient use their implant as they use their natural teeth? I think it really depends on the dentist's style. If you want the patient to use the implant for a long period of time, you be very cautious. If not, you might think it's better to let the patient do whatever he or she wants to do, and if it fails, you can place it again. People who think like that would consider excursive force as no big deal. There's no denying that in terms of mechanical and biomechanical aspect, if you give a lot of excursive force, it gives unfavorable impact to the implant, such as screw loosening. Do you agree? Let me tell you something I heard recently. In the past, the people believed it was very fortunate to die without suffering too much. These days, people say the lucky ones live long without suffering from diseases. Longevity without any issues. I think that is the way to go. The patient can live on without any discomfort. If there's one less screw loosening, that means more comfort on the part of the patient as well as the dentist. ID Yeonji-shi, thank you for the clear and detailed answer. I will have the patient use the temporary for some time and I will observe. Good doctor, thank you for the meaningful lecture. There are especially many comments today. Thank you everyone for your keen interest. In return for your interest and the participation in real chat, we are going to send coffee coupons after a lucky draw, and they're going to be sent individually. Professor Lee, it's quite late. Thank you for answering the questions. And is there something you'd like to say to fellow dentists? Perhaps a word of advice? I don't believe I am fit for giving you eye-opening knowledge or advice. That being said, when we do occlusal adjustment, contouring, or polishing, when we receive training, we constantly hear people telling us not to do something, not to touch upon margin, and so forth. This message is continuously repeated to us, and therefore, when we treat patients, at times we find ourselves quite timid. When you do polishing or contouring, some people just ask the lab technician to do it. However, if you take a look at the work of lab technicians, they may make the restorations look glossy, but they touch upon margins and they do a much worse job. Dentists feel more responsible because it's our patients. Lab technicians may be able to do it in a very expert way and very fast. But dentists can do it very nicely as well from the start. If you get used to it, garner knowledge, and get the habit of doing it, hone your skills, you'll be able to get good results. Nowadays, we divide work of dentist and work of lab technician. However, if dentists can take over that role, the overall treatment could become much more smooth. Some people believe that finishing and polishing is not very important. However, you need to do the final stage with perfection for patient satisfaction and long-term usage of the prosthesis. And I believe that's why there are so many questions today. I would like to extend my gratitude to Professor Lee Jun-seok, who has come all the way to Prosthodontics on Friday from Cheonan on Friday. Thank you for watching Prosthodontics on Friday. How did you like the lecture with Professor Lee Jun-seok? I hope you are able to get tips and guidelines on implant prosthesis occlusal adjustment and correct way to do finishing. Regarding the questions that weren't answered today, they will be addressed via replies. Next time, we are going to invite Dr. Park Ki-hoon from Seoul Ace Dental Clinic to talk about fixed implant prosthesis for fully edentulous patient. Thank you for watching once again.
감사합니다.
수고했습니다.
네, 감사합니다. 감사합니다.